Assalamu alaikum. This is Dr. Amna. Today I will discuss the Down syndrome and antenatal screening. This presentation is basically a mixture of uh, green Down syndrome talk of 2019, and also the I have also included the patient information leaflet counseling. So before I discuss the Down syndrome, I just want to say a few things that Down syndrome is very important because if in the exam they must ask some of questions from Down syndrome, whether they will include the whole station. And if you are not having complete station on Down syndrome, you have to talk about Down syndrome in one way or another. So because if I want to actually tell the points of normal pregnancy care. So, whenever a normal patient who is not having any medical condition or any risk factor, she wants to become pregnant. So, if she comes for preconception advice, so it is recommended that we will tell her that she should be pregnant when she is in best of her physical and mental health, and for that we will ask her to um, quit smoking, and if she is used to do smoking, and if she needs any help for that, we can uh, connect the patient with the NHS stop smoking services, and then we can if ask the patient to stop drinking alcohol and any recreational drug, and we advise the patient to start folic acid 400 microgram, because in the patient who is not having risk factor for neural tube defect, she will take 400 microgram folic acid. If the patient is having any risk factor for neural tube defect, or she like she's diabetic, or she is obese, also if she is having some anti-epileptic drug also cause neural tube defect in the baby, then she needs 5 milligram of folic acid. And 5 milligram folic acid is not available over the counter. She needs prescription for that. Then she will, when we will ask patient to stay in good health and then take folic acid and then conceive. And whenever she conceives, she will come to us for booking visit, and that is at uh, 10 after 10 to 10 weeks of pregnancy. The ultrasound at 6 to 7 week of pregnancy, which is said as called as um, viability scan. It is not recommended in normal pregnancy care. The viability scan at 6 7 week is only recommended if the patient is having some medical condition in which there is increased risk of miscarriage. Then we will advise the patient in the preconception clinic that when you become pregnant, we will check for the fetal heartbeat. But in the normal pregnancy, it is not recommended to do the viability scan, because in NHS or in anywhere in the world, nothing is free, because someone is paying cost at any level. So we have to use the resources wisely where it is really needed, and we should not waste the resources. So we will not call the patient at 6 7 week. We will ask the patient to come at 10, around 10 or weeks. And when she comes, we will book the patient, and then patient will be uh, we will assess the general health, and we will label any risk factor she is having, and then we will ask the patient to we will do the ultrasound scanning, in which we will see the CRL and crown rump length, and also we will see knuckle translucency. Then we will ask the patient, we will do some blood test, booking blood test. So in the booking blood test, we will screen for few infections like HIV, syphilis, and hepatitis B. So then we will screen. This screening is for all pregnant women. If patient refuses to have this screening, we will ask first the concern of the patient, why she is refusing. And we will check her mental capacity, that if she's given the reasonable argument that if she's having these infections, these are can be transmitted to the baby, we have the management plan in place to prevent these infection passing on to the baby, and still she refuses, then we should ask the concern and address the concern, and then um, we will ask again in the later part of pregnancy. We will screen the patient whether she is high risk or not, and so that we can counsel her better. Because these there are some stations as well, and MRCG party, where patient says that I don't want to have HIV screening or syphilis screening, then we ask the patient what are her concerns. So she tells her concern. If we can address that, it's fine. If not, she's saying that I just don't want to. Then if we see there is no, she's not a high risk patient, we will tell her that their option is still there if she ever changes her mind. So after doing the screening of these infections and her blood group and um, RH antigen, and also the hemoglobin level, we see these in the normal patient. So after that, also in that visit, we will ask the patient to offer the patient the aneuploidies screening for Down syndrome, Edwards, and Patau syndrome. So these screening are done by, we will offer the patient combined test at before at 10 to 13 plus weeks. So 13 plus 6 weeks. So the combined screening will be done, in which we will take some blood tests. We check beta HCG, pregnancy specific proteins, PAP-A, and also the beta HCG and knuckle translucency along with maternal age. We will calculate the patient risk of having Down syndrome and Edward and Tau syndrome. So if the patient is found to have high risk of developing Down syndrome, then we can offer patient the non-invasive prenatal testing. And after that, we can, if it comes positive, then we will give the patient um, um, choice of invasive procedure like chronic villus sampling and amniocentesis, whichever patient likes to have. So after that, if everything stays normal, we are assuming that everything is normal. Then we will move and have the mid-pregnancy scan. So patient will have around 20 weeks, we will have mid-pregnancy scan. We will have detailed anomaly scan. Then we will, everything is normal. Then we will um, during the third trimester, whenever patient comes, we will have check the blood pressure and everything, vitals, and check the general health of the patient. And from the 24-week onward, we will start measuring fundal height to see whether baby is growing normal. And then at 36 week, we will discuss with the patient the plan of delivery. And for the plan of delivery, we have four options like home birth, midwife, and alongside midwifery clinic, stand alone midwifery clinic, and hospital. Four things basically: home, uh, midwifery clinic, which are independent, and alongside midwifery, which buildings are alongside hospital. So whenever a patient needs to be transferred to the hospital, it will be easy. So these are four options for the patient, and we will discuss the choice of analgesia, and also um, uh, continuous electronic fetal monitoring is required or not, and what is the mode of birth and timing of birth. And then after we will use the third stage, we will manage the third stage of labor actively or not. It's a patient choice if everything is normal. So then we will encourage the patient after delivery to mobilize, and we will assess the thrombosis, VT prophylaxis risk on every visit on the start at the booking, and then whenever we see that there is new risk factor, and at the delivery, we will assess the risk factor for VT, and patient ask the patient to mobilize, and uh, good hydration, breastfeeding, and then um, we will discuss the contraception with the patient according to her health and choices. And then we will call the patient at 6 week follow-up, in which we will check patient is doing well and baby is well, she's breastfeeding or she is taking contraception well. So this is the normal care of pregnancy. So whenever there is, we will offer the patient the Down syndrome screening. So we have, we will tell the patient what it means. So the combined test, this is used to screen Down syndrome, Edwards syndrome, Patau syndrome between 10 to 14 weeks. So it include maternal age, ultrasound measurement of knuckle translucency, and free beta HCG, pregnancy associated plasma protein (PAPA). So eligibility criteria for CRL is 45 to 84 mm. So this is between 10 to 14 weeks. If CRL more than 84 mm, then quadruple test will be offered. It means that a patient is beyond 14 weeks. If result is between, so how we interpret the result of combined test? So test will tell us that patient is having risk of developing Down syndrome. Her value is 1 in 64. So 1 in 64 means it is more between 1 in 2 to 1 in 50. So she is high risk patient. Whenever patient is giving value 1 in less than 1 in 50. 1 in 2 means two of one patient. If there is 1 in 1, it means this is a diagnostic patient is having Down syndrome baby. So 1 in 2 to 1 in 150. She is high risk for having Down syndrome baby. So now we how combined test in twin pregnancy is interpreted. This is also these questions are asked in the MRCG part 2. Detection rate of trisomy 21 of the first trimester combined test in twin pregnancy is similar to that in singleton pregnancy. A detection rate of combined test is 95%, and there's a 5% false positive rate. So, however, in monochorionic twin pregnancy, the false positive rate is twice as high as in singleton pregnancies, because an increase in knuckle translucency is one fetus could be complication of twin to twin syndrome. So there can be fluid. We can explain the patient is a more fluid in the at the back of the neck. So in dichorionic twins, an individual risk factor is given for each fetus. We can say that this fetus one is having 1 in 20, 1 in let's say 1 in 300 risk, and fetus two is having 1 in 300 or 1 in 250 risk. Both are low risk. So in monochorionic twins, we calculate risk for each fetus, and then we will give the average of 2. It means we can tell about the whole pregnancy. We cannot, in monochorionic, we cannot predict for the each twin. And if a patient comes after 14 week, and if it was not possible to obtain a knuckle translucency measurement, that is after 84 mm, then patient more than 14 week into your pregnancy, she will be offered a test called quadruple test. Blood screening test between 14 and 20 week of pregnancy. This only screens for Down syndrome and is not as accurate as the combined test. So this is the chart from the TOG, in which it shows that if we screen the patient for having trisomy 21, maternal age, according to maternal age, the detection rate is only 30% and false positive is 5%. But if we take first trimester combined test, it's 90% detection rate and 5% false positive. If we take the cell-free DNA test, this is non-invasive prenatal testing, its detection rate is 99% and false positive rate is 0.1%. This is expensive than first trimester combined test. So it is not generally offered to the all patients. Only it is offered if because it's expensive, and right now we don't NHS don't offer it to all patients. But if patient is having first trimester combined test positive, it shows that patient is at high risk of developing this condition. From 2021, NHS recommend that patient should be given the option of cell-free DNA test, so that its detection rate is 99%. So after if it comes positive, then you will give the patient, we will ask the patient to have CVS and amniocentesis, because in the CVS and amniocentesis, there's a 1% risk of miscarriage. In the guideline, Green Top guideline, it's mentioned in 1% risk, but in the NHS patient information leaflet, it's mentioned 0.5%. So it is having the risk of invasive tests have risk of um, miscarriage as well. So we will offer those patients, we will offer cell-free DNA test. So next, if a patient comes on after 14 weeks, and then the quadruple test will be done, alpha fetoprotein, free beta HCG, unconjugated estriol, and inhibit A. This will be done. And this detection rate of this is 70 to 75%. And this can only detect the trisomy 21, not the Edward and Patau syndrome, which is trisomy 18 and trisomy 13, and false positive again 5%. And these are other triple test and double test. Everyone is having a false positive rate of 5%, except cell-free DNA, which is having a false positive rate of 0.1%. So how if it comes that patient is having the condition, having positive combined test, so how will you tell the patient what is Down syndrome? So if patient does not know what is Down syndrome, first you can ask that if patient comes and you have to explain the patient that your combined screening is positive, and how will you explain this to the patient, and how will you counsel her further? So you will tell the patient that each human cell typically contains, first you can ask her, always ask her first, because sometimes patient has already searched internet and she comes with the information. So you should always ask first patient what she knows, because it will save your time. So you will ask, do you know what is Down syndrome? She says, no, I don't know. Sometimes patients say, yes, I know. It means that this does not have marks in this station to explain the Down syndrome. So you should not start from the start that I will tell you what is Down syndrome. Patient knows, if knows, then it's okay. Then you will, if she says, I do not know what is Down syndrome, then you will say each human cell typically contains 23 pairs of chromosomes, which totals 46. In baby, half chromosome come from father and half from mother. In Down syndrome, your baby is having one extra chromosome. So baby has 47 chromosome due to some change in eggs and sperm. In Down syndrome baby, a Down syndrome baby has characteristic facial features and learning disabilities. There are a range of disabilities. Some baby have small level of disability, while some need help in day-to-day activities. These babies have heart problem and gut problem. So you can offer the patient the non-invasive prenatal testing. This is from the patient information, NHS patient information leaflet. This statement from there. From spring 2021, NIPT will be offered as an additional option for women in England who have a cancer, who have chance 1 in 2 to 1 in 150 of having a baby with Down syndrome, Edwards syndrome, or Patau syndrome, following combined or quadruple screening in single and twin pregnancy. NIPT is not diagnostic. We will tell the patient that this is if we go for NIPT, this is again screening test. This is not a diagnostic test. NIPT is not a diagnostic test, and women with their partners with a higher chance NIPT result who wish to know for sure if the baby has, we will offer this test to the woman and their partner with a higher chance NIPT result who wish to know for sure if their baby has or does not have one of the conditions. Can choose to have further prenatal diagnostic tests such as amniocentesis or CVS, chorionic villus sampling, to confirm the result. NIPT is blood test taken from pregnant women to assess the chance of baby having Down syndrome, Edwards syndrome, and Patau syndrome. So we will explain the patient if we will tell the patient that if it again it comes positive, because it's a screening test and we cannot say that patient baby is having the condition. It just shows that baby is having a chance of Down syndrome. So we can offer you chorionic villus testing and CVS, and amniocentesis, because we will explain the patient, because some patient may choose to terminate the pregnancy if it shows that baby is having Down syndrome. So we will give this overview to the patient that why we are doing this invasive testing, because if you know for sure that baby is having, you have option of termination of pregnancy. So chorionic villus testing, CVS should be performed between 11 and 13 plus 6 weeks. It should not be performed prior to 10 weeks of gestation. We can explain the patient that we clean your abdomen, tummy with the antiseptic and may use a local anesthetic injection to numb a small area. We insert a fine needle through your tummy and into your uterus womb to take the sample. We use an ultrasound probe to guide the direction of the needle. And for the amniocentesis, if you have to explain to the patient that amniocentesis is usually done between 15 and 20 weeks of pregnancy, but it can be done later. We take a small amount of amniotic fluid, the water around your baby inside your uterus for testing, and the small sample contains some of the baby's cell, which contains genetic information. Occasionally, for fewer than 7 in every 100 women, in 7% of the women, you can explain this to patient, 7% or 7 in every 100 women, we cannot take enough fluid at the first attempt, and we have to reinsert the needle. After taking the needle out, the baby is observed for a short time on ultrasound, and amniocentesis results are usually available in around 3 days. So CVS can be done abdominally and transcervical. Um, Commonly, it is done abdominally. So if he asked what are the routes for CVS, these two routes. For amniocentesis, I have explained. So I have now a possible risk of amniocentesis and CVS. These are together, almost same for both. For miscarriage, I have told you that Green Top guideline has mentioned 1% and 1 in 100 women. And in the patient information leaflet, NHS has mentioned 1 in 200 women will miscarry. So most women say these procedures are uncomfortable rather than painful. You may notice cramping and period-like pain for few hours. This is normal. You can take paracetamol for that. You do not need to rest or stop driving after that. 6 in 100 women are offered repeat procedure due to inability to get sample during first procedure. 1 in 200 women will miscarry even with experienced hands. Less than 1 in 1,000 women develop serious infection. You will receive 2 results, one after 3 days and second after 2 weeks. So if patient says that if the combined screening is positive, let's say it's showing that 1 in, let's say 1 in 140 or 1 in 130, whatever is the high risk for that. So you offer the patient that the chances that patient can have this is positive for down screening. And we think that we will offer you NIPT, and then we will offer CVS and amniocentesis. Because I'm mentioning all these questions because patient may not ask all the question in one station, but you should know all the variation of questions, because if she asks this question, you can answer this, and if you ask another question, you are prepared to answer. So patient says, I want to terminate now on the basis of screening test. Patient say, I don't want to go through all this trouble. I just want this pregnancy to terminate. So first we will ask, what is the reason of termination? Maybe this is not the reason that this is screening. We will first ask and rule out why she wants to terminate the pregnancy on the screening test, whether she has proper understanding of that this is only screening test. This is not a confirmatory test. Or there are chances that she is having some other problem, like a domestic abuse. And what is, because if they have mentioned the patient is teenager or these risk factor, we should identify these risk factor, because they mix the things in the station. Sometimes they will add a young patient, and she says that I want to terminate, and just screening test, you give proper advice to the patient. She says, no, I still want to terminate. So you will ask, is this the only reason or there's something behind? So you can ask, do you live with your partner? So how do you consider yourself a happy couple? Do you feel safe around him? So that she will come up with some answer. If she says no, then you can emphasize on telling her that this is the point you should mention to the patient. The screening test shows there is chance that with your circumstances, because with your circumstances is very important, patient age and any other risk factor in the patient. Screening test shows that there is chance that with your circumstances, for 150 babies born normal, 1 baby has Down syndrome. Okay, so if her reading is 1 in 60, we will say there is chance with your circumstances for 60 babies born normal, 1 baby has Down syndrome. It does not mean that that baby is yours. Okay, we need to confirm before going for termination. So I can give you patient information leaflet. I'll connect you to the pediatrician so that you have better understanding of Down syndrome and its concern. I'll connect you to support group where you can talk to the parents who have Down syndrome babies and how they manage, so that they have informed decision. So that you have informed decision. Basically, you will tell her that it is just screening test. We need to first confirm. Once it's confirmed, then you can have the option. And because only because you show that it's a positive does not mean your baby will have this condition. It can in turn result in the termination of a normal pregnancy. So we will tell her, this is first we need to confirm. And even it is confirmed that she's having Down syndrome, because Down syndrome has range of disabilities. Maybe baby can live on its own. So we can tell her that there's a range of disability. First, we obviously she has the right to choose for termination of pregnancy on this ground, but we will tell her that first you have the all information so that you have the informed decision. So this is the one more thing I want to say, that there are certain, if a patient asks a question from you and you don't know the answer, so there can be chances that you, single doctor cannot know all the answers. So it's normal, but it is acceptable even for RCOG, even for everyone in the world. It is acceptable. The point which is not acceptable is that you give the wrong information to the patient. So it is not sin if you say I don't know the answer, but if you give the wrong information, that is the negative point. So how to, because this is why we say multidisciplinary approach, because what we don't know, we ask from our colleagues. So how will you come out of that situation? So patient asks you a question and you don't know the answer, and you should accept it. You can say that I don't know the answer of your question right now, but at the end of this consultation, I will talk to my consultant and I will let you know about the answer. So you will not leave the patient that, okay, I don't know. Just, you cannot say that, because if you don't know, from where patient will get information? So you will say, like, I don't know the answer. So at the end of this discussion, I will ask my consultant and let you know. So thank you so much. If there is any question, please let me know in comments.